Let's move forward. We got next set of talks. We got three speakers who will be popping up now with the some important topics. And to chair this particular talk, I'll be inviting a chairperson, Dr. Reema Bansal, Advanced Eye Care PGIM ER from Chandigarh. Dr. Reema, you there? Hi,
Yeah.
good to see you. Dr.
Hi.
Amit Khosla from New Delhi Gangaram Hospital. Dr. Amit.
Good evening.
Yeah. Oh, we can't see you, so I thought I'll wave hand. Okay.
Yeah.
Then we got our moderator, Dr. Soumya Yava Basu from Hyderabad, LVPEI. So, sir, I request you to now take over, and we got three speakers. You can quickly start. We'll take all the Q&A at the end, so we'll just allow all the speakers to finish their talk.
Thanks so much for introducing the session to the audience. I think we need to start off quickly, and our first speaker for the Uveitis session is Dr. Reema Bansal. Dr. Reema Bansal is Additional Professor of Ophthalmology at the Advanced Eye Care, PGI Chandigarh, and she will take us through the imaging in uveitis and how it helps us in looking beyond what is obvious to the eye. Reema.
All right. Thank you so much, and I apologize for this. So the ancillary investigations in uveitis, we know, are the backbone of uveitis workup, more so for the posterior segment diseases and also for anterior uveitis in some cases. They help not only in making or confirming the diagnosis that we are considering, also help in ruling out certain differential diagnosis and monitoring inflammation during the follow-up. But there are a lot of cases where they help us look beyond the obvious, and that's what I'm going to share with you some clinical scenarios where imaging helped us look much beyond what was obvious on clinical examination. So here we have a case of a 39-year-old woman who presented with a chronic loss of vision in the left eye, 3 to 4 months. So what you see clinically, it could be a retinal or a subretinal or a choroidal lesion. And when we look for any clinical clues, we see that there were no signs of inflammation. So the most easily available invasive investigation, we do a spectral domain OCT, and we find that there is a hyperreflective complex in the subfoveal, in the subretinal space with breach in the RPE. So we take the retrospective history accordingly, and we find that the patient was on steroid cream for some skin lesions for a year, also was a known case of anxiety and depression. So we now know what we are working towards. It's not a case of uveitis actually. So we do an autofluorescence, and there we have the diagnosis. We have the findings of chronic CSC in the left eye. All that we do, we just confirm on fluorescein just to show that this was a confirmatory investigation to see that this was a case of chronic CSC. So all that we needed to do was stop the steroid cream, change the lifestyle modifications, and have this patient at 3 months of follow-up where we can see the fibrin has gone. Clinically, the vision has come back to 6/6, and even the spectral domain OCT is back to normal. Similarly, another kind of patient with somewhat similar looking foveal lesion presenting with 6/24 vision, a young male, a middle-aged 38 years old male with 15 days history of poor vision in this eye. He had history of dengue almost a month ago with platelets 30,000. And again, we think of whether it's a retinal or a subretinal or a choroidal lesion, but there are no signs of inflammation again here. So we do an OCT again, and at least this rules out that this is not a subretinal or a choroidal lesion. So we are seeing some hyperreflectivity in the inner retinal layers. Fluorescein was normal to our surprise, and again, we are back to being clueless what's happening in the left eye. So here we do the autofluorescence, and this is what tells us what is going on. So a hyper-autofluorescent lesion in the fovea tells us this is nothing but an altered pre-retinal bleed because of thrombocytopenia for what the patient had. And all that we had to do, we didn't have to give any treatment to this patient, just observed him, the vision coming back to 6/6 in a couple of weeks, and all the OCT showing resolution of this altered blood. So when we do the autofluorescence, this was at baseline, and at repeat at follow-up when the vision was 6/6, you can see a normal autofluorescence. Now, these kind of cases obviously are quite straightforward to deal with. There is extensive vasculitis, bilateral frosted branch, and we investigate the patients accordingly. All that you would need is a fluorescein, but won't really play much role. But what you do if you have a patient like this who's presenting with blurred vision? more in the left eye as compared to the right eye. So what we see, there is vitritis significant and hazy media, and we don't see much beyond that. So unless we do a fluorescein, it tells us not only there is extensive leak all over the vessels, and it tells us the pattern of vasculitis. So it's actually a small vessel vasculitis that the patient is presenting with just in the form of significant vitritis. Another patient just presenting with floaters, clinical examination not so obviously giving you any clues, but if you do a fluorescein, we see that there is vasculitis in both the eyes, extensive 360 degrees, and the phone pattern tells you that you're probably dealing with a case of Behçet's uveitis. Again, a very obvious case of vasculitis. So all that you need to investigate in terms of vasculitis, it could be TB, sarcoid, or syphilis, or any other entity. But what you see on fluorescein that there is extensive capillary non-perfusion. So you have to treat that component also. So here we are dealing with an ischemic form of vasculitis, which needs additional treatment in the form of laser or anti-VEGF injections. Now here we have a patient clinically presenting with vitreous hemorrhage in the left eye. So obviously it's a unilateral disease when you see clinically, but when you do a fluorescein, it tells you that it's not a unilateral disease, but this is a bilateral disease where you have fibrovascular proliferation occurring in the fellow right eye in the inferior periphery. So we need to take that also into consideration and treat the fellow eye also. Another patient presenting with vitreous hemorrhage, we planned this patient for vitrectomy, but before taking up the patient, we were fortunate to do an angiogram in the left eye, and for obvious reasons, we found these multiple NVEs and NVD. But to our surprise, clinically, the right eye was normal because the posterior pole was normal. So the fundus, the fluorescein was also normal in the posterior pole, but the upper temporal periphery revealed a large neovascular front, similarly nasal periphery and upper nasal periphery. So there was so much going on in the fellow eye, which looked normal to us, and we investigated the patient accordingly. And so we took him up not only for vitrectomy in the left eye, which was doing quite well after endolaser, and also underwent scatter laser photocoagulation in the right eye. And this is how the follow-up at 5 years shows that we could take up the right eye also for timely laser photocoagulation to prevent the ischemic sequelae. And if we compare the baseline angiogram of the left eye, this is what it was. And this is what he was after 5 years, doing fairly well. Right eye, these were the NVEs in the right eye. And this is how at 5 years the right eye is behaving. A case of exudative maculopathy, all that you see extensive hard exudates. And if you pay some attention, there are some sheathing of vessels in the right eye more obviously. And OCT just tells us there is subretinal fluid, there is subretinal hard exudates, but what beyond that? What are we dealing with? A fluorescein white field just gives you straight away diagnosis of retinal aneurysms. And here we are dealing with a case of idiopathic retinal vasculitis and neuroretinitis. So here it's just the imaging that tells us the diagnosis, and we really don't have to investigate elaborately for this patient. Another case of ischemic vasculitis, a very young male, almost in 20s, presenting with sudden loss of vision. You can see multiple cotton wool spots in the posterior pole. You can see severe arterial attenuation, and if you go down to the periphery, the multiple hemorrhages. Now we know we are dealing with ischemic vasculitis, but what beyond that? We do a fluorescein, and we found that there is massive occlusion in the right eye, and left eye was almost no perfusion. So these are the eyes which, rather than paying attention to getting investigations and spending time on them, I would be paying more attention to treating these patients to prevent blindness and take up them for laser photocoagulation rather than waiting for them to come back with a list of investigations. That would be important, but after taking prompt treatment steps. Similarly, another young male patient, a slightly different clinical picture, bilateral, multiple hemorrhages, loss of vision 3 weeks to the extent of counting fingers, and looks like CRVO, but a young male presenting with sudden loss of vision. So when we do the fluorescein, we see that the right eye perfusion is extremely less, but left eye, there is no perfusion at all. So this is an ophthalmic emergency, and we had to take up this patient for multiple consultations from hematology, rheumatology, and cardiology. And we found that this patient turned out to be HIV positive after we got all the investigations done. Not only that, the lymphadenopathy revealed AFV positive from cervical lymph nodes, suggestive of lymph node tuberculosis. So this was again, the clue that we got was from fluorescein angiography. A patient with dense vitritis presenting to you with sudden loss, floaters and hazy vision in the right eye. So before taking up the patient for a fluorescein or an OCT, it's a good idea to examine the periphery. Clinically, they may not be able to see because of significant vitritis, but a wide field of TOS, simple of photography, would tell that there is a head-like lesion in the upper nasal extreme periphery, and we're dealing with nothing more than toxoplasmic retinochoroiditis. So just a wide field photography gives us all the clues of the clinical diagnosis here. A patient undergoing right eye vitrectomy for vitreous hemorrhage, the surgeon is happy, the vision is 6/9, all looks very normal, and except that the fellow eye has some vitreous floaters, 6/9 vision. So what to do? We do an angiogram, we find that there are some residual areas in the right eye which need a supplement laser, but left eye, to our surprise, was even worse than the right eye. You see extensive 360-degree scapulary non-perfusion, NVEs, and would need more prompt treatment rather than doing a supplement in the right eye. A young boy presenting, this was just a 5-year-old boy, I remember, who presented to us with bilateral loss of vision. Now we know that the macula is knocked out. There's some kind of necrotizing retinitis going on, but what is it? So we just do a simple OCT and we find their complete loss of retinal layers except the internal limiting membrane. And we know that probably the patient, we are dealing with SSPE, and we investigate the patient and we find that this was a case of subacute sclerosing panencephalitis. So here, just the OCT is good enough to give you the diagnosis of what you're dealing with. This was a patient, for obvious reasons, disc edema in the right eye, was referred from outside to PGI as a case of neuroretinitis, and the patient actually landed up to our department rather than going to neurology. Fortunately for him, so what we saw were these subtle choroiditis lesions in both the eyes, which were probably ignored by the referring physician. And we did a combined fluorescein and ICG, which showed that there were the whole the choroid was full of granulomas in the early and the late phase. Maybe challenging for some discs. If you look at the optic discs, small discs with peripapillary atrophy, decreased vision for 4 months, 6/12 vision. So before we do visual fields or refraction or something like that, just an autofluorescence gave us the clue that these are nothing but optic nerve hydrusins. And we confirm it on the ultrasound. So just a simple case, sometimes these drusen's may be buried and partially, and we may miss them if we don't do the autofluorescence. A patient with serpiginous-like choroiditis treated elsewhere presents to us and clinically looks like almost healed lesions in the left eye, unless we do an autofluorescence, and we find that there are some areas which still need treatment. So autofluorescence is, as we have our own experience also, is a must-do investigation in all these cases of choroiditis, where it tells us that whether the clinically healed lesions are completely healed or not, we get all the hints from the autofluorescence. This was a lady who was managed elsewhere as a case of PKH, and she just presented to us in the remission phase. 6/6 vision in 2016, and she had almost stopped her steroids because everything was fine. And she came for a second opinion, and all that she said was that she has some kind of discomfort in the left eye. Her vision was 6/6, clinically normal, no anterior segment cells, no vitreous cells, nothing in the eye going on. So the fluorescein tells us that there is some kind of leak from the optic disc in the late phase, but nothing beyond that. So should we do any treatment? We do ICG, or what do we do? How do we go ahead? We do an EDI OCT, and we find that the top panel that you see, the right eye choroidal thickness was normal, but in the bottom panel, you see that the left eye, there was a massive increase in the choroidal thickness. And this is what her complaints were. She just had heaviness in the left eye. So sometimes not ignoring the patient subtle complaints and taking them up for these ancillary investigations, gives you a lot of information. And so we confirmed on ICG there were subtle granulomas which were more prominent in the late phase. So this was nothing but an early subclinical recurrence of VKH disease. So we had this patient, a female, 23 years old, who presented to us in 2018. She was the daughter of a patient who was already with us with a diagnosis of uveal effusion syndrome. Now she comes to us with decreased vision since 3 weeks in the left eye. Her refraction was kind of misleading, hypermetropic in the right eye and myopic in the left eye. So what would we be dealing with? On examination, you see the right eye was normal. The left eye, there is annular coleochoroidal detachment, or maybe just the choroidal detachment clinically that you see on conforming on fluorescein. You have tortuous vessels. So what beyond that? We do an OCT. The top panel is the right eye, which is normal. Left eye, there is bumpy RPE, but there is no fluid, nothing else. So what do we do? The autofluorescence tells us there is leopard skin appearance, much more prominent in the left eye, and the right eye is normal. And this is a very classical appearance, and we think in lines of uveal effusion syndrome. And this is what we further, led us to investigate the patient. We did the exhale lengths. They were small, not really an anophthalmos, but yes, she was small exhale length. And this, we got the MRI done, and she turned out to have coledochoroidal detachment with mildly thickened sclera in the left eye. So we made a diagnosis of pupil effusion syndrome. And to tell you the truth, that this patient later on, 18 months later, after this diagnosis, presented to us with a full-fledged exudative detachment in the left eye. A case of heel vasculitis, you can see sheathing of vessels in the right eye and something going on in the macula. Patient just presents with subtle, non-specific ocular complaints. And when we do the OCT, there is cystoid macular edema. Now, is it a recurrence of choroiditis, or is there an underlying choroidal neovascular membrane? We do a combined fluorescein and ICG. We see some hypolesions in the macula in the early phase, and there is leakage in the disc and in the macula on fluorescein in the late phase, some hypocyanescence persisting in ICG in the late phase. So consistent with cystoid macular edema. But do we really see a membrane? We are not sure. So all that we know is cystoid macular edema, which we anyway knew from the OCT. So what next? We do a OCT angiography, and we see that there is a neovascular complex on the choriocapillaris frame. So this was actually an occurrence of choroidal neovascular membrane and inflammatory CNVM in a patient with heel vasculitis and choroiditis. So to summarize, that imaging in uveitis, when of course it helps us to look beyond the obvious, it's extremely important for establishing your clinical diagnosis. But the choice of investigation depends upon the site of inflammation, the kind of clinical presentation. So we just have to pick up the right modality of investigation for the particular pathology. So many times we need to perform multimodal imaging to get the useful information. And thank you very much. Thank you, Toss, once again.
Thank you so much for this excellent talk, Reema Bansal. If I may summarize what I learned from this talk, I mean, the photographs are phenomenal. While the obvious thing about imaging in uveitis is to recognize the pattern and to recognize the complications of intraocular inflammation, beyond it, what we were looking, I think the first thing we learned is to rule out a non-inflammatory pathology. The picture of the pre-retinal hemorrhage in a dengue patient or subretinal fibrin in CACR or optic nerve brucin are typical examples where we have ruled out a non-inflammatory pathology. The next thing is to look at any coexisting lesions. And I think your case of Irwan was very typical of how the identifications of aneurysms helped us in making the diagnosis of Irwan in a patient presenting with submacular hard exudates. I think an important point that we learned here in this talk was that it's not always an invasive investigation which is going to tell you more about the kind of ocular inflammation. Many a times there are non-invasive investigations, and again going back to your pre-retinal heme, which picked up nothing on FFA, but the autofluorescence showed up, it lit up there and showed us that we're dealing with a pre-retinal heme in a dengue patient. So non-invasive investigations are sometimes more useful than invasive investigations. So that would be a last takeaway. Just a quick question here. The title of this talk was Looking Beyond the Obvious. And one of the reasons why we investigate such patients is when the clinical picture does not correlate with the visual acuity. Where else would you think you would be interested in investigating the patient of intraocular inflammation? This question is to both of you. Apart from vision not correlating with the fundus picture.
When the vision is not correlating, then we do. I didn't get your question.
No. So, the reasons why we investigate our patients, why we do ocular imaging, apart from the reasons that we discussed, when it's a clinically normal looking eye and it's not correlating with the visual acuity, you go ahead and investigate the patient. Apart from this, what other factors could lead you to investigating these patients, imaging these patients? By investigation, I mean imaging.
Yeah, so I think when you have multiple differentials,
Hmm.
clinically, for example, if you have frosted branch vasculitis, it could be anything. So um, we anyway, as a routine, we investigate these patients because imaging is something that it's not. Now you just pick it up that this case would need. There's some most of the etiologies have a fixed imaging pattern, because if you have a vasculitis, you're going to do a fluorescein unless you cannot form your opinion without doing that. Similarly, if you have patients of exudative retinal detachment, where they would obviously be coming with a very decreased vision to the extent of counting fingers. But all exudative detachments are not VKH. You may be dealing with chronic, you may be dealing with fibrinous CSC, you may be dealing with uveal effusion syndrome. So these kind of etiology where you can have multiple differentials, we would do ancillary because sometimes not doing the imaging, you tend to be prompt in your treatment and you would do more harm than good. So there it's important to rule out when and because you have a condition where you want to give steroids, but on the other hand you have a condition where you want to withdraw steroids. So VKH versus CSC, just an example I'm giving. So unless you confirm and you start away go straight away go with your treatment, I think it's very important to do these investigations. And otherwise, yes, when you have still clinical correlation not matching with your clinical presentation, you see something else, the vision is pretty low, doesn't count with it, then we need to go for probably multimodal imaging.
Thank you. Thanks so much for the extensive discussion today. We quickly move on to the next talk by Dr. Amit Khosla. He's a senior consultant at Sir Gangaram Hospital in New Delhi, and he has been spearheading the introduction of biologics into the uveitis therapy for quite some years now. So he's probably one of the best people to discuss this topic. Dr. Khosla, please.
Thank you, Dr. Bas. Can you see my slides?
Yes, we can.
Okay, so I'll be speaking biologicals in uveitis, the expanding indication, the present and the future. And the role of biologicals cannot be more emphasized if you are in teamwork with adult rheumatology and pediatric rheumatology. This year, I complete 25 years with adult rheumatology and 21 years of co-treatment with the pediatric rheumatologist. So what is a biological? It's a recombinant protein or antibody against the cytokines or the cell surface receptors. So it's made from a living cell. It can be classified as per the source, whether it's a human, UMABs. MAB means monoclonal antibodies, or you can be ZUMAB, the humanized one, or the chimeric ones. So you can have the idea of the origin of the biologicals from the name. So they are basically biological products derived from living, and it is a complicated process to make them. So you cannot, it's not like cloning the same chemical nature of the other one. You are going to have different biological processes for every company making the same product. So you need to first sequence it, vector it, grow it in a protein, and then sell it. And today in the COVID time with the use of tocilizumab, everybody know what a biological is, and it's difficult to copy it. Now I just want to tell that in systemic diseases, you have the cytokine stimulators like interleukin, interleukin, IFN, and TNF, and these are the ones which act on the receptor of the cell. And intracellularly, these drugs, these receptors stimulate the JAK1 and 2. And the JAK1 and 2 are the end chemicals which stimulate the process of inflammation. So you can either target the cells outside the cell on the cell membrane, or now you can target the inner chemicals, like the vaccination, we're having mRNA, or we're having the dead organism or the virus stimulating it. So like mRNA, you are targeting the internal cell, that is the JAK inhibitors. So you could, the advantage of the JAK inhibitors is that which is the future are going to be oral and cheaper. And these are all, the out one are generally subcutaneous or intravenous injections. So it is when you copy a biological, it's called a biosimilar, and it has to undergo the same rigorous analytical and clinical assessment. And remember that you may have a different chemicals in different biologicals. And sometimes as you improve on them from a chimeric to a human, from a lexilol to adalimumab, they are better chemicals. Now, if you were to see the history of biologicals, we were having it from 1998, we had the etanercept, and now we have the JAK inhibitors. This we have evolved, and we have learned from the rheumatologists that these drugs help reduce the inflammation. So you can classify them into TNF inhibitors, the standard one. I'll just name the ones which are available: infliximab, adalimumab, and etanercept. Or you have the lymphocyte like B cell inhibitors like rituximab, or you can have the interferons. So what has COVID taught us? COVID has taught us that we flatten the curve to reduce hospitalization and mortality. So in uveitis, what we need to do? Should we give drugs only when you have the surge? So in uveitis, we also over 10, 20 years, you may have 5 or 6 episodes. So should I be giving, say, Ozurus injection or intravitreal steroid at every surge? Or I should be giving a drug round the year to prevent the flattening, to prevent the morbidity and blindness. So last month, there's a review article in Survey which says that, yes, our aim is to prevent all these complications. So now I'm saying we need to prevent each one, and we have to anticipate which patient will go into the chronic stage, which will take few years, how many will take decades to get control. So generally in uveitis, we are too late in our diagnosis and treatment initiation. We don't target our therapies properly, and we feel that uveitis is going to go away. It's not going to keep coming back. So we tend to give 2 months, 3 months of steroid every year, and the patient recurs. So these are the patients where you will think of drugs on a longer basis. Now, this is an article which says that the vision loss in an active disease over the years, 5 years is more. Sometimes you have a slightly active disease and you have an inactive disease. So if you were to follow these patients for 10 to 20 years, you will see that some develop CME, ERMs, 618, 612 vision. Should we have treated them 20 years ago to prevent that vision loss? So we've been using DMARDs or disease-modifying agents like methotrexate and azathioprine. But if you were to use the biologicals, we will still have flares in SPA. It's not going to go away. So remember that you will have some flare. We are not looking for total cure. We are looking for control and a partial remission. This is a patient of VKH who was been treating elsewhere, developed recurrence for on methotrexate developed low counts, was referred to me, and I started the patient MMF. Was I late enough to start biologicals? This is a follow from 2017, 2019. Now here the pigment loss had occurred, so I should have been more aggressive enough in giving adalimumab to prevent the sunset syndrome. So this young lady just came to me last week, has still 6 vision, more pigment loss, and has been on adalimumab for 3 years with 6 vision. So should I have started it at this point where I lost the pigment, or it was too late already? So it's important is to anticipate what complications you're going to have and how you can prevent the pigment loss. And this young lady still has patches of vitiligo on her face, and she's more worried about the vitiligo than the eye. So what we have learned from rheumatology is that remission is important, and you should always start treating before the deformity sets in. So if you were to start a adalimumab or a rituximab in arthritis, where already deformed joints are there, you're not going to win the battle. So it has to be early, start early, anticipate. So our aim of treatment in uveitis today is to control the disease, cure it, and make it steroid free. It should be remission free for 2 to 5 years, depending on the severity, before you think of tapering it. So it's always important to be aggressive and start systemic immunosuppressive early. The aim is to prevent cataract, glaucoma, and CM. What pediatric rheumatology has taught me is that cataract has to be avoided at all costs in GI, because the early surgery is difficult to put in the lens. At the moment, we are all doing topical steroid, regional steroids, followed by systemic, and we use DMARDs or the biological DMARD. DMARD means disease-modifying anti-rheumatic drugs. So at present, what we all understand is that we need to bring down the steroid to less than 10 milligram within 3 months. In children, we need to be steroid-free, that is both topical and oral steroids, or we shift to these 3 drugs. But the side study shows us that when you start the DMARDs, you tend to have a recurrence. You have to start early because they take almost 3 months to act. So we are looking at a drug group which can give us much faster resolution, because at the end of 1 month, if I were to think the child or the adult is having remission, I want to shift. It takes 2 to 3 months for methotrexate and azathioprine to act. So we need to have some other drugs where you can prevent vision loss. And as you all know, that 55% of patients who are on DMARDs require a change or were given a combination of drugs. So the site trial from which analyzed data on DMARDs from 17 to 2005 showed that methotrexate azathioprine had about 60 to 70% efficacy in reducing the steroid activity to less than 10 milligram, or in some patients had a remission. So still we had about 30-40% of patients who were not responding, and we needed some other group. And biological has shown us the way that yes, they, in addition to the DMARDs, can help us control the disease and prevent loss. So I will just tell you the drugs which we use today in India, which are available and which you need to know about. So we have the we don't have the original drug Humira in India. We have the biosimilar drug here. We have both the original and the biosimilar in India, infliximab. And etanercept, we have the original drug. But etanercept sometimes aggravates the uveitis in HLA. We do not use it in patients with history of uveitis. The other is rituximab, which is both available in the original and biosimilar form, is used for rheumatoid arthritis and scleritis. Tocilizumab, we have the original one, which has been used for COVID, which can be given intravenous or subcutaneously, and it is more effective in those patients with vasculitis and CME. Now, this group, the JAK inhibitors, we have baricitinib and tofacitinib, which is oral. It's being tried in GI. A trial is going on. We have few centers in India, which my center is part of this trial, and there's one trial internationally going on in uveitis also. And so we should have some studies whether they will work in, especially in GI. The systemic diseases which with eye lesions which are being regularly used is rheumatoid arthritis, ankylosing spondylitis, SLE, psoriatic arthritis, inflammatory bowel disease, JIA, sarcoidosis, and Behçet's. So these are diseases where the rheumatologists are already using biologicals. And if you have an eye symptom, in combination, these patients benefit. Here's a patient who presented to me just with scleritis, no lung or renal involvement, had GPA with sinus involvement and a deformed nose. It took us about 18 months to control the patient with methotrexate and rituximab. There was a trial for JIAs which showed that in combination with methotrexate, the adalimumab group definitely gave a big advantage, and this trial helped us consolidate the use of biologicals in uveitis. For adults, we have the Visual 1, Visual 2, and Visual 3 study, which showed that with biologicals, you can almost bring down the dose of steroid, but maybe not eliminate them in adult. And this is a composite, both intermediate and posterior uveitis. So I'd just like to show a case of a 14-year-old female who was diagnosed with Behçet's, came to me in 2012, who had vitritis, hyperemic disease, and sheathing, had perivascular leakage, disc leakage, was started on various drugs and had complications tried from methotrexate to azathioprine to cyclosporin. 2012 developed a hypopion. We tried everything, and she had recurrences. This is her history. We tried every drug until she developed some complications. And finally, we were able in 2015 to start adalimumab, and the Indian drugs were available. We gave her infliximab. Now she's on adalimumab. And now she's a confident young girl who comes alone to me in 2020 with a vision of 618. And we could control the Behçet's disease and let the now young lady be independent and be able to see 618 vision. So the drug helped us preventing the chronic. So Behçet's is one disease where you can start afresh from the beginning, de novo, using biologicals, because we know these cases are going to be chronic and side-threatening. For those interested in biologicals, we have the IGO had a UVA, full UVA articles in one series. We have this systemic immunosuppression. And there's a focus initiative which tells you the guidelines for using biologicals and DMARDs. So those interested can read these articles in details. There are plenty of other articles today in the rheumatology journals. If you were to access the rheumatology journals, you will find a lot of articles for uveitis. And then you can start using biological, but remember you need to use it in session with rheumatologist, because the initial guideline did not approve, the Indian drug controller has not approved it for use for ophthalmologists. In ocular, what we use is, at present, we are using in Behçet's, GIA, retinal vasculitis, orbital inflammatory disease, ocular pemphigoid, scleritis, optic neuritis, and thyroid disease are the various indications besides uveitis which we are using biologicals. Here is a patient who presented to me in the COVID time, a young child of 5 years with panuveitis and serious detachment in the left eye. And I started the patient immediately on methylpred, oral steroid, gave methotrexate, and see how the child responded. This is 2020 when the child came 18. This is June of 2021. The child has 6/9 vision. So the patient was given oral IV steroids, oral steroid with methotrexate. At the end of 2 months, we felt the child is not fully responding. We added adalimumab, and the child has a quiescent eye, now has 6/9 vision.
Dr. Khosla, you need to conclude the.
Okay. So the safety of TNF is always a question mark, where we have a lot of side effects, but the side effects are limited to infection. So you need to rule out tuberculosis, demyelinating disorders, congestive heart failure, malignancies. And we need to give a second immunosuppressant because you can develop antibodies to the TNF blockers. And in today's world, before you start the TNF, the patient should be vaccinated. So we had a patient of GPA. We've deferred the rituximab for scleritis, started a patient of mycophenolate and methotrexate, so the child could have vaccination. This is our experience. We published these few articles on our experience of the side effects. So we need to understand there are side effects of biologicals, and you need to remember that Behçet's and GI are the ones where you can start de novo or as a second line in the other member. And biologicals do not act as fast as steroid. For induction, you require methylprednisolone, and you require teamwork with rheumatologists and internists. Thank you.
Thank you so much, Dr. Amit Khosla. We'll take up the questions as soon as I finish my talk. I'll quickly move on to mine, and then we'll discuss both the talk. So let me introduce myself. I'm Retina and Uveitis faculty at LV Prasad Eye Institute, Hyderabad. And I think Dr. Khosla needs to unshare his, yeah. So I think I should be able to share my slide now. And I'm going to discuss the role of therapeutic vitrectomy in uveitis. Now, when we talk of therapeutic vitrectomy, we need to remember that the vitreous is like a dumping ground for all intraocular inflammation. So in the vitreous, you're going to find the microbes or their products, DNA, RNA, proteins. You're going to find inflammatory cells and their products, which are the cytokines and the chemokines. And in case you are dealing with a non-inflammatory pathology such as a tumor, you're also going to find the tumor cells there. So it's very obvious that vitrectomy has been used and very effectively used for various types of diagnostic biopsy, which includes culture microscopy, PCR testing for the infections, then cytology for the tumors, and flow cytometry, ELISA, choroidal biopsy for various kinds of, to gauge the amount of inflammation and to characterize the type of inflammation. It's also been used for optical vitrectomy, where you clear the visual axis and improve the vision of the patient in a quiescent eye. What we are going to discuss here today is the use of vitrectomy as an anti-inflammatory therapy. Now, the basic mechanism of vitrectomy as an anti-inflammatory therapy is to remove the pro-inflammatory immune cells, which are directly releasing the cytokines, as well as the helper T cells, which are making the immune cells release these cytokines. During the process, we are also able to remove the antigenic load from the vitreous. So this is going to modulate the immunological milieu, the overall environment inside the vitreous, because the antigenic stimulation is now lost, and it will allow more rapid clearing of the pro-inflammatory cytokines as well as better drug penetration. Now, there are some very well-established objections to the use of therapeutic vitrectomy in uveitis, and some of these are very understandable. One of them is, these are mainly extrapolated from the recommendations for cataract surgery in uveitis, and it says that you should not be used in an inflamed eye because there's a very high risk of retinal breaks in inflamed eye, and once you've done a vitrectomy, it's more difficult to assess the amount of inflammation inside because the vitreous haze is lost. And finally, that vitrectomy cannot cure uveitis, which we all know. It's not going to cure the uveitis. So let's see how it is going to help us. Now, to best use vitrectomy as a therapeutic tool, you have to clearly understand the purpose of doing the vitrectomy. The purpose is faster resolution of the inflammation and reduce dependence on the corticosteroids. Also, to remove the media opacities, vitrectomy can never replace the role of systemic therapy, be it the anti-inflammatory systemic therapy, for example, in sarcoidosis, or the antimicrobial systemic therapy, for example, in tuberculosis. So we have to clearly understand why we are doing the vitrectomy. And second thing is we have to select our patients very carefully. So some of the patients where we should avoid doing a vitrectomy are those with hypotony, because vitrectomy can induce further hypotony in these patients. Pediatric patients are best avoided because the vitrectomy is going to induce an early cataract in these patients. And then while vitrectomy is very useful for making a diagnosis of infectious uveitis, usually as a therapeutic agent, it is not required because most forms of infectious uveitis respond very promptly to the antimicrobial therapy. Then you do a therapeutic vitrectomy. You should not do a therapeutic vitrectomy when you are not able to see the posterior segment very well, and obviously avoid it in a one-eyed patient as a primary therapy. Some of the things that you need to keep in mind are to use small gauge vitrectomy, 25 or 27 gauge. Make sure your trocar is sharp, especially when you're reusing the instruments. Keep relatively low suction and avoid doing any sweeping movements with the cutter inside the eye. Most of these patients have posterior vitreous detachment. This has to be understood very well. So we just need to complete the vitrectomy without needing to apply any additional suction for the PVD. And if there is an incomplete PVD, just cutting the attachment at the disc or applying a gentle tug at the disc is very sufficient. You can see the picture on top is of complete PVD where you just finished the vitrectomy without inducing anything else. And in incomplete PVD, you are able to cut in this area and finish your job. It's better to do an air exchange at the end of surgery. It prevents leakage from the port, and have a very low threshold for suturing the port, whatever gauge of vitrectomy you're using, because leakage from the side is the most important problem that you have after doing surgery. Now, some of the studies that have looked at the therapeutic outcomes of vitrectomy in uveitis are this review by Becker and Davis, where they looked at 44 intervention case series, where visual acuity was found to be improved in 68% of the eyes, and there was reduction in inflammation and cystoid macular edema. Then a more recent study on the site study data on the predictive factors for intermediate uveitis said that pars plana vitrectomy is one of the important factors that are predictive of remission of intermediate uveitis. We studied patients with bilateral TB uveitis, where one eye underwent vitrectomy and the other did not, and we compared both the eyes. We found that at the end of 1 month, eyes that had vitrectomy had faster resolution of posterior segment lesions and also a greater improvement in visual acuity. This is an example of such a case where the picture on the left-hand side is the one that underwent pars plana vitrectomy. You see the lesions on top have disappeared almost at 1 month post-op, and there are no new lesions. While in the non-vitrectomized eye of the same patient, you have some of these lesions persisting with nearly the same amount of brightness, and this lesion increasing further in size despite having the same systemic therapy. So this shows the therapeutic benefit of pars plana vitrectomy. To summarize, the anti-inflammatory potential of pars plana vitrectomy needs to be explored further, and the main purpose is not to treat uveitis here, but faster resolution of inflammation and improvement in visual acuity, and a reduced dependence on corticosteroids and avoiding the side effect of corticosteroids. we need to clearly understand the purpose of doing this vitrectomy and set clear goals for the surgery, and always keep in mind that doing the surgery does not alter the course of disease, and these patients will still need chronic immunosuppressive therapy. Thank you for your attention. And in case you have still not joined, please do join this LVPI uveitis series, which is meant for general ophthalmologists. And we are now in the second module of this course. Thank you very much. Do we have time for questions? MC?
Yes, we can use the time, Dr. Sommer.
Wonderful. I see there are 10 minutes left, and I think my questions are for Dr. Amit Khosla first. Thank you for a wonderful presentation. I think it was very, very comprehensive. I wish we had a little more time. And, one of the points that I was reminded of during your presentation was this about the step ladder approach. And one of the speakers in an USI meeting mentioning that we need to move on from the step ladder attitude to the elevator attitude. And I think JIA or Bechet's are great examples where we need to, have an elevator attitude where we straight on move on to the biologic therapy rather than going step by step. What will be your take on that?
So my take is that steroid are the fasting acting, and if you have you give methylpred, an oral steroid, if at about 3 weeks, you get a rough idea that disease is under control, the vision is back, it's a good response to steroid, and you may be able to maintain that drug with methotrexate or azathioprine. So I tell my patients that, a full dose methotrexate or azathioprine is like 20 milligram of steroids. So it's not as effective as steroids. So if at the end of 1 month, your disease is not fully controlled, you still have 6-12 vision, and you are seeing that the patient is requiring high dose of steroid, these patients will not get maintained, especially in children, as methotrexate as a azathioprine. Then you can think of. So we need to form guidelines on what are the markers at 3 weeks, what are the markers at 6 weeks, and how we can change over from one drug to the other. So I tell patients, especially of GIA, who says how many years of biologic, I'll say, if it took me to make you remission free in 1 year, I need at least 2 years for it to remain controlled, 2, 3, then to start tapering. So in how many months you become disease free? Now, disease free is 2 elements. One is that you are 6/6 vision, you are asymptomatic. But on imaging, you are positive. Say intermediate uveitis, you still have the leakage, you have disc leakage, you have cells, but you may be 6/6. Patient is happy at 6/6, but the patient is not controlled. So you need to take parameters on all the parameters in front and then decide if this patient will require long-term.
Right. So a quick question from the perspective of a general ophthalmologist. When you first put up the thought of starting biologicals to the patient, what points do you definitely cover in all your uveitis patients? One, from the perspective of the prognosis of the condition, and the second, how the treatment will be done from the patient's point of view.
If you take JIA, one of the first person to give the guidelines was Dr. Stephen Foster. And I've had few patients, thanks to Dr. from LVP, patients referred to me and to Dr. Foster, where we started about 8 years back. We started a patient on infliximab, now adalimumab. Patient, I think, is co-managed by LV Prasad and me. And this child had a minimal flare and cells and a posterior subcapsular cataract coming up even after 1 year of treatment. So a small marker like a appearance of a cataract or appearance of occasional cells will tell you this child is not controlled, or the appearance of a BSK. So if you see a patient upfront who has BSK, who has synechiae, who has cataract, this patient requires long-term treatment. You may think of being non-aggressive in a patient who has no cataract, no BSK, and has just few occasions, is a new patient who has been on treatment for GI develops uveitis. So the severity of the disease you will monitor according to the findings which you have.
So I asked the same question to Dr. Reema Bansal. When you broach the point of starting biologicals to a patient for the first time, what do you cover? Like, how do you counsel the patient about the prognosis of the condition with starting of biological, how it affects the disease course, and what care the patient has to take during this period? Just the initial discussion, not the details.
Okay, yeah. So the very fact that we need to start the biologicals, we discuss with the patient, of course, the patient's parents in detail, that the amount of treatment that the child is getting is not enough, and we need to be more aggressive. But nowadays we have a much safer, drugs in terms of biologicals. Only thing is we need to discuss the financial issues, number one, and the side effects, and we need to tell them that it's going to have a better control. Initially we may start with, and frequent dosing of the injections. Maybe if you are giving adalimumab 2 weekly, and later on we may switch to 4 weekly depending upon the response. But overall it's good for the patient's maintenance of remission of uveitis. And affordability is a major issue that we have to discuss very smoothly and very sensitively with the patient's parents. And we being a multi-speciality tertiary care center, we have the advantage of rheumatologists always with us. And so we keep the rheumatologists in loop, and we discuss with them, so the patient is getting the inputs both from the rheumatologist and the ophthalmologist.
Thank you very much. Again, going back to Dr. Khosla about the use of JAK inhibitors. Do you think, JAK inhibitors being an oral drug and having such a broad spectrum effect, they are going to be a panacea for, most forms of uveitis in future, or there will still be a role for more specific targeted therapy, such as anti-TNF therapy or anti-B cell therapy? What will be your thoughts on this?
At the moment, the side effects are the limiting factor. Yesterday, I compared azothioline and methotrexate and MMF. 50% of times, the counts or the diarrhea or the liver enzyme become a limiting factor to increase the dose. 50% time, you are shifting the drug to other, not because it's not getting controlled, because you can't give the full dose. Similarly, things are going to happen with TNF also, because TNF, the risk of TB with TNF, or of herpes zoster, or the GI infection with tocilizumab is going to be there. So I had this patient who came to me with a GIA who had a cataract of 3/60 in one eye and 6/9 in the other eye. So I felt this patient is an ideal case to prevent cataract in the other eye, start adalimumab upfront. This child was given adalimumab, methotrexate, did one eye surgery. The other eye, still after 5 years, is 6/6. But at the end of 6 months, the child developed chickenpox. So the child has been off adalimumab. I gave it in the beginning 6 months for the methotrexate to act. So you can also use adalimumab upfront for a few months, get it controlled, and then let it maintain on this. But these side effects are going to be a problem. With JAK inhibitors, you're going to have, since they have affect a lot of pathways, you're going to have anemia, hematological problems, infections also come as an issue. So you will have to play between various biologicals until we have personalized medicine where we know this disease is interleukin-6, this is TNF, this is this, until we are able to pinpoint all diseases based on one cytokine which is causing the problem.
Thanks very much. I think, so Raj, do we have any questions from the audience that we can take up at this time?
I have not seen Dipti or Arpita. Did we hear something?
So, Dr. Basu, I have one question for you.
Yeah.
If a patient comes to you with uveitis with cyclitic membranes, right, would you do a vitrectomy with lens removal, or you like a phakic, or you keep the patient pseudophakic and then try to remove the membranes over the ciliary body?
Yeah, I think that would be a very tough situation. It depends on the extent of cyclitic membranes. If I'm able to, it's the only eye, and the cyclitic membranes are very extensive, that would be the typical situation. I would rather make the patient aphakic and do a thorough removal of the cyclitic membranes. On the other hand, if the other eye is doing relatively better and this eye we can wait a little longer, then I would prefer to do the cataract surgery first, make pseudophakic, and then go ahead with the vitrectomy and removal of the membrane.
Okay.
Thank you. And any other thoughts, Dr. Rima Bansal, on this?
I agree, but for cyclitic membrane, I think I would prefer to remove the lens also and just make the patient aphakic, because the long time goal for me would be to have an inflammation, a formed eye, no hypotony, and maintaining the pressures as well as the control of inflammation.
But putting oil in a phakic eye, if the patient has to maintain hypotony, is more difficult putting oil in a phakic eye than a pseudophakic eye. Doesn't that catch-22 come in?
Yeah. So the lens acts as a barrier because, ultimately we have seen all these patients, the oil coming into the AC, BSK setting in, and,
Yeah. But these eyes, 5,000 centistokes does a good job.
Okay.
For long-term maintenance, and that's what we do. So if you have complicated cataracts with hypotony, we do lensectomy, vitrectomy, and 5,000 centistokes oil.
Thank you.
I have a question for you, Dr. Basu. Vitrectomy in uveitis, what is your experience, personal experience in terms of cystoid macular edema? Because we also published our series in 2017, finding our main conclusion was microincision surgery is very safe in uveitis, contrary to the previous thoughts that in uveitis eyes, and all that. So how do you find cystoid macular edema? Because I find they do come up in some of the eyes. Vitrectomy is not a cure really for.
Yeah, in fact, that's a great question because unlike the inflammatory scores, which really come down very well, especially the focal lesions, if there's a choroiditis lesion or a retinal vasculitis, these respond very well to vitrectomy. On the other hand, the cystoid macular edema does not respond very well to vitrectomy. In fact, we have had quite a few cases where there has been CME post-operatively. Not in the immediate post-operative period, but even in the delayed post-operative period, we have had CME in these patients. So,
also in the delayed, I find on follow-ups, they keep on having it.
So probably the mechanisms that are working with CME are different than what are happening at the retinitis or choroiditis or the retinal vasculitis lesions. I think, this is something
systemic factors rather than ocular.
Will be good. Nice question for, pondering for future. So thanks very much, our esteemed guest faculty, Dr. Reema Bansal, Dr. Amit Khosla. I think we had a very good introduction for the general ophthalmologist to what is happening at the frontiers of uveitis, and this is very relevant to all of them. I hope they benefited from it. Thank you very much.
Thank you, Dr. Basu.
Thank you so much for the opportunity.
Thank you.
Wonderful. And so we wind up the session here. Thank you so much, Dr. Basu and Dr. Khosla and Toss and Dr. Honavar. Thank you so much for having uveitis session in this meeting.
Thank you so much. Let's give a round of applause to everyone being so productive, informative with the information to our delegates also. With this, I think we have come to the an amazing, the event coming to the end of the day now, day 2 also. So with this, we would like to again thank all the logistic team. I can see Hallmark Events is there. Thank you, audiovisual team, Grover team, everyone, and all the committee from your side also for Vision 2021. Running it on time and with such a informative speakers, question answers. It has been pleasure and amazing to host you all. So with this, I think do we have a closing notes from our chairperson?
I think thank you so much. Everything is good, and we've been hearing on the WhatsApp group about the wonderful, all the sessions going fantabulous, and Dr. Honavar doing great job. And I would say that grand finale of the meeting is by uveitis. So thank you so much.
Yeah, that's the positive way to look at it. Thank you so much. Yeah.
Awesome.
Thank you so much.
Thank you, Dr. Basu. Thank you, Dr. Khosla. And thank you, Hallmarks. Thank you, organizers. Wonderful.
Superb. I think with this, we are good to close this.
Yeah. Can we have a photo?
Yeah, sure.
Amit, can we have you on the video? Yeah. So who's taking? Are you taking?
How will I share with you all? You can just take a print screen. That's the best in virtual host.
Yeah, Doctor, I'll take the screenshot and I'll share in the faculty group.
Okay.
Perfect. Can we all raise a thumbs up? Yeah. Pose. This is a virtual pose.
Dr. Amit, I need the 2 thumbs ups from your side.
You'll see one. I have a wide angle camera.
Yes, great. I'll share it in the faculty group, ma'am.
Thank you.
Thank you so much.
Awesome.
Thank you. Thank you so much.
Bye.
Thank you all.
Bye.
Bye bye. Have a nice
Thanks.
day.
Bye.
Bye.
Take care, guys. Be safe.
Good night.